Good morning, sir.
Good morning.
Siddharth.
ভালো
Sir
আছিস?
will not be available here, sir, today because he is having some personal work. So I will be moderating the session.
Okay.
Yes, sir. So we have today with us Sija from Peerless Hospital who presents laparoscopic nephrectomy surgical procedures. I think we can start now, sir.
Yes, you can start.
Yes. Dr. Sija, you can start now.
Good morning, everyone. I'm Dr. Srija from Peerless Hospital and BPRI Research Center. Today, I'm going to present operative procedures of open and laparoscopic nephrectomy. So, indications of nephrectomy are carcinoma of kidney, severe renal injury with avulsion of renal pedicle, hydronephrosis with non-functioning kidney, renal calculus with gross destruction of kidney, chronic pyelonephritis, pyelonephrosis of kidney, donor nephrectomy for transplantation. So we can go for a nephrectomy in open and also in laparoscopic approach. In both cases, we have transperitoneal and retroperitoneal approach. For open transperitoneal abdominal approach, it is used for renal malignancy and trauma. Retroperitoneal loin approach is used for infective and benign pathology. So first we would like to discuss about the nephrectomy by retroperitoneal loin approach. So position of the patient for approach to right kidney, the patient lies in a left lateral position. The arm is supported on an armrest. The left lower limb is kept flexed at hip and knee to 90 degrees. The right lower limb is extended, supported on a pillow kept between the two legs. The area between the right costal margin and the iliac crest is opened by elevating the kidney bridge and breaking off the tip. The position is maintained by a leather strap or a broad band of adhesive, fixing the iliac crest and the greater trochanter to the operation table. The right shoulder is also anchored to the operation table by adhesive strap. So, first the skin incision, we start from the renal angle, that is the angle between 12-3 and lateral border of erector spine. We pass the incision downwards and forwards about 1 centimeter below the 12th rib to a point about 2 centimeter above and anterior to the anterior superior iliac spine up to the lateral border of rectus sheath. Subcutaneous tissue is excised in the same line. Then we divide the superficial muscles. The first layer, posteriorly there is latissimus dorsi and anteriorly there is external oblique muscle and aponeurosis. On the next layer, posteriorly there is serratus posterior inferior and anteriorly there is internal oblique muscle and aponeurosis. Then we divide the thoracolumbar fossa. An incision is made at the thoracolumbar fossa, taking care not to injure the subcostal nerve. The incision is carried backward up to the erector spinae muscle. Using a gully swab with blunt dissection, the parietal peritoneum is stripped off from the transversus abdominis muscle. The transversus abdominis muscle is divided by carrying forward the incision in the thoracolumbar fossa. Then we expose the perinephric space. The cut margins of the thoracolumbar fossa retracted. The parietal peritoneum is further stripped off medially. This exposes the perinephric space. The perirenal fossa, that is the fossa of Gerota, is lifted at the radial angle with 2 pairs of hemostatic forceps and incised with a knife in between. The incision is then extended with scissors. Once the perirenal fossa is incised, the pale yellow perinephric fat is exposed. Deep to this fat lies the kidney. Then the kidney is mobilized by blunt finger dissection. The upper ureter is identified, dissected, and divided in between plugs. The cut ends are ligated. Proximal ureter is then followed up to the hilum. The renal artery lies posterior to the renal vein. Approach from the posterior aspect allow better tackling of the artery. The artery should be ligated before the vein to avoid congestion. The upper pole is mobilized by separating the adrenal from the upper pole of kidney by blunt dissection. Then hemostasis is checked. Tube drain is placed at the renal fossa. The muscles are closed in layers with running suture and skin closed with interrupted suture. Now, nephrectomy by transperitoneal abdominal approach. For this, usually if it is an elective one, transverse oriented incision or subcostal chevron incision is preferred. But in case of trauma, if there is suspicion of injury to any other organ, then midline incision, midline laparotomy is preferred. The peritoneum is opened and the small bowel is packed to the opposite side of the abdomen. On the right side, the peritoneum of the posterior wall is incised along the lateral aspect of ascending colon, hepatic flexor, second part of the the colon, duodenum, and the head of the pancreas are swung medially to expose the anterior surface of the kidney and its pedicle. On the left side, the peritoneal incision is given along the lateral aspect of the descending colon and spleen, which are then swung medially with the pancreatic tail. Mobilization of the kidney, if it's a benign pathology, then we dissect immediately outside the fibrous capsule. If there is severe fibrosis, then we may need to dissect outside the perinephric fat. In case of renal tumors, we dissect outside the perinephric fat. Earlier, the adrenal was dissected along with this, but if there is good preoperative imaging and there is no evidence of tumor in adrenal, it is no longer considered necessary to remove the ipsilateral adrenal gland. If there is many accessory peripheral dilated veins, it warns the surgeon that there may be blockage of the main venous drainage by obliteration with the tumor. During mobilization, excessive traction of the renal pedicle should be avoided. Early ligation of the renal vessels prior to full mobilization decrease the vascularity, and it is one of the advantage of abdominal over the loin approach. In the pedicle, the renal vein lies anteriorly, but we should ligate the renal artery first, because kidney with the venous return ligated but arterial flow intact will enlarge and any hemorrhage will dramatically increase. The artery, vein and ureter should be ligated separately. The vessels should be ligated in continuity prior to division, preferably doubly ligated or transfixation ligation. Linear stapling devices are also used nowadays. For laparoscopic nephrectomy, the advantage is the recovery time is greatly reduced. And this.
Hello, Sriya.
Yes, sir.
Before going to the laparoscopic part,
yes, sir.
Few points. In the indications, you should have also mentioned a condition, the polycystic kidney with uncontrollable hypertension. That is also another indication of nephrectomy. You know, the polycystic kidney gives rise to hypertension. If it is uncontrollable by medical measures, nephrectomy may be necessary. And what are the, you have mentioned a few approaches in open method. There are several other approaches also. As for example, actually it is divided mainly in two parts, either flank approach or anterior approach. Flank approach, you have mentioned this, what you have mentioned is subcostal. But there are other approaches like supracostal, just above the 11th or 12th rib. And also there are through the 12th rib bed, some urologists prefer also that, excising the 12th rib. These are also approaches in flank approach. And an anterior on anterior approach, you have mentioned rightly that in case of emergency, it should be through midline, and but you may do also by subcostal or chevron incisions. That means bilateral subcostal incision. And they, for example, in rare situations, abdominal approach. In case of very large tumor in the upper pole and involving the suprarenal,
thoracoabdominal approach may be needed.
May be needed.
Mobilization of
and there is another approach that rarely done in pediatrics. pediatric surgery, or where there is very thin patient needed bilateral renal procedure. There is dorsal approach. In prone position, dorsal lumbotomy. That means it is no muscle is cut. You have to proceed between this sacrospinalis and the latissimus dorsi and through the fascia, as you have done in your anatomy class, kidney from back, like that. That is another approach, though very rarely done. It is indeed done in the pediatric surgery and very thin patients. Okay, okay, and and also you must have known. You mentioned also this how to these pedicles are tackled. You have to ligate the vein first, definitely, and sometimes ligation is not enough. You may have to suture. If it is very wide, then may need suturing also.
Yes.
Along with ligation, there is okay. We put to laparoscopic part.
Okay. So now we discuss the laparoscopic nephrectomy. The advantage is the recovery time is greatly reduced. The disadvantage is if there is bleeding during laparoscopic nephrectomy, it can be very difficult to control. So there is always a risk of conversion to open surgery. The approaches may be extraperitoneal or transperitoneal. The laparoscopic nephrectomy is nowadays a method of choice when nephrectomy is required for benign disease or for T1, T2 renal carcinoma. So we discuss the laparoscopic transperitoneal nephrectomy. 3 ports are placed here. I have shown the port placement. We mobilize the colon. The fossa of Geroda is incised.
What should be the position of mention position of the patient?
Position of the patient will be kidney position, as I have mentioned in the open loin approach. The patient will be on the patient will be placed at the lateral position with
Actually, in though in most of the cases it is done totally lateral approach, but some surgeons prefer also semi lateral position. That means 30 to 45 degree flank up. Means in supine,
okay,
and you pad up posteriorly in which side you are doing.
okay.
Okay.
Sir.
Okay. Proceed.
Okay. So colon is mobilized, then the fossa of Geroda is incised, the hilum is dissect out the pedicle, then there is sequential ligation and division of the renal artery and the vein. The kidney is mobilized all around. The ureter is ligated and cut. The specimen is retrieved through infraumbilical incision. Hemostasis checked, drain replaced, and abdomen is closed in layers. This
Yeah.
is yes.
How ureter is dealt? Is there any difference in from the open approach? Actually, in case of laparoscopy, you should not resect the ureter first. You identify it first, and then use it as a guide and lifting the kidney. It will help you lifting the kidney up. And you should not resect it at the beginning.
Yes. First kidney is mobilized, then we will resect it.
Yes. How? Okay. Now, in laparoscopy, how this case is prepared in case of, so you have mentioned transperitoneal, no? You have mentioned transperitoneal. Okay.
Yes, sir.
Okay. Proceed.
Sir, also there is a retroperitoneal approach. I don't know much about that approach.
There is also in similar fashion, transperitoneal as in open, there is a retroperitoneal approach is also there, and most of the neurosurgeons preferring that. If it is on a single side, retroperitoneal approach is also same. This position is also full flank position, and you have to importance is that because retroperitoneal space you have to take measures to prepare the space That is important because there is no space. As you have
Yes.
done in case of hernia surgery, you have to prepare the space. There are several methods, and some surgeons do it just deepening the incision, and by finger movement they clear the fat in between the kidney and the psoas muscles. Some use the balloons, as you have seen in case of hernia surgery. You may use balloon also. Balloon may be separate, or balloon may be attached to the trocar, as you have seen in hernia procedures. Okay, so there is space has to be prepared if it is you want to do by retroperitoneal approach. Okay. Now, what you have so what are the what you have shown in your picture, that is
Yes, sir.
actually hand assisted, isn't it?
Yes, sir.
What picture
That's
you
it.
have shown
Yes, sir.
after this post-op image, that is
Yes, sir.
actually hand assisted laparoscopy, isn't it?
Yes, sir. Yes, sir.
That means specimen is retrieved by
Yes.
hand.
By an infraumbilical incision.
Yes, yes. But is there any other method of removing the specimen? Yes, you may actually retrieve by the morcellation. You know, you have to pick the kidney in a bag, and by piecemeal, by either mechanical morcellation or by instruments are there for morcellation, you may remove it. Okay, without hand assistance. Okay,
So morcellation will go for if it is for benign disease.
yes. Okay, proceed.
So now I go to partial nephrectomy. The partial nephrectomy is more difficult procedure than the total nephrectomy due to the renal parenchymal vascularity. The operation should, however, be considered when only part of the kidney is involved in the pathology, but the remainder of the kidney is healthy. It is indicated in case of small renal cell carcinoma, particularly for carcinoma in solitary kidney, or in case both the kidneys are affected by carcinoma. In case of tuberculosis with solitary calcium cell and stenosed calcium system with healthy remainder. As for the surgery or the incision is difficult, the depths of the abdominal incision. Therefore, in elective situations, a blind approach is usually favored. Good hilar access is essential, as temporary occlusion of the renal artery with a soft cross clamp is necessary. 15 minutes is the warm ischemia time, and there is permanent loss of function by 30 minutes. Cooling of the kidney increases the parenchymal tolerance of ischemia. The arteries and veins to the portion of the kidney to be excised may be ligated in the hilar. For this, we can do preoperative angiography to locate the blood supply. So after ligating, there will be a color demarcation between the perfused and non-perfused kidney, and this will be a guide to the surgeon for choosing the line of incision. The capsule is incised in a coronal plane over the pole, and it is reflected back as anterior and posterior flap. The kidney parenchyma is then divided along the line of demarcation, and with the hilar occlusion clamp in place, the vessels in the cut surface are secured and ligated prior to release of the clamp. Open calyces are closed with a continuous absorbable suture, and the capsule is folded back over hemostatic watch, covering the raw area and loosely sutured. To check, we can also push a methylene blue through the urinary catheter and see if all the calyceal systems are calyceal system are closed or not. For that, we need to place an urinary catheter before. Thank you, sir. Thank you, everyone.
Hello.
Yes, sir.
Yeah. How you be cautious when doing radical nephrectomy?
Yes, sir.
radical nephrectomy. What do you mean by that?
Sir, for radical nephrectomy, we need to excise the perinephric fat along with the kidney and the lymph nodes also, sir.
Yes, you don't have to exercise. You have to take the fossa of Gerota along with.
Along with symptom.
And how will you deal if there is propagation of tumor mass into IVC?
So beforehand, operatively, we do CCT of the CCT. CCT usually shows if there is any thrombus or extension of the tumor in the renal vein or IPC. We can also do an angiography to check.
Yes. Then you may have to do
Then
removal of the IVC.
yes,
must
we need to end the IPC.
You must thrombus from the IVC.
Yes.
And if it is a large thrombus, you may have to go for venous bypass. IVC may have to bypass IVC. That is definitely a big procedure.
Yes.
But for small thrombus, you just clamp the vein for temporarily and remove the thrombus.
Yes.
Okay. Any other suggestion or question?
Yes, sir. I would like to add, like, what are the indications of partial nephrectomy? Rija?
Rija,
Yes.
you
Yes,
have
ma'am.
told some.
Please be more clear about the indications of partial nephrectomy.
Ma'am, I can't hear, ma'am. What is the question?
Indications of partial nephrectomy.
Indications of partial nephrectomy.
Yeah.
Ma'am, if there is a small tumor, or if there is a tumor at a solitary kidney, or if there is bilateral renal carcinoma.
Small means how much small? The tumor should be less than 4 centimeter. That is, it should be less than T1, less than, or it should be a T1A tumor.
Yes.
Yes.
Okay, then we can go ahead with the partial nephrectomy.
Yes.
But not then. Which cases will you prefer a partial nephrectomy?
Yes, ma'am.
In which cases will you prefer a partial nephrectomy? Like, what are the indications?
What is contraindication?
Indications. Indications. In the case of a T1A tumor, you will do a partial nephrectomy. But what are
Yes,
the
ma'am.
more exact indications?
Benign for benign pathologies.
No, not in benign. You will do in a malignant case only, where the tumor is T1A tumor.
Yes,
or if the patient is having a single kidney, the patient has lost a kidney due to some other medical cause, and he or she is having a single kidney, then
Yes,
we will do a partial plan for a partial nephrectomy. The patient is having a familial cause, underlying familial cause, then we will plan for a partial nephrectomy. The patient is having bilateral renal cancer, then we will plan for a partial nephrectomy.
Yes.
Okay?
Yes, ma'am.
Okay. So if we don't have any questions, we can end the session today here. Hello, sir.
Okay, Siddharth. You may end.
Yes, sir. Yes, sir. Thank you, everybody. That's all. Thank you, sir.
Thank you, sir. Thank you.